Thank you very much, Dr. Mohammed, for your presentation. Thank you for inviting me to this conference and this session. It's my honor being here in Qasr Al Aini conference. Thank you for the conference president. It's very hard to speak after Dr. Mohammed Naguib because some energy in the hall is still after him, but I will discuss the GERD endotherapy. We can call it endotherapy now. I don't think you're expecting to hear something new from me, but we'll just demonstrate the different techniques and different devices we can use in endotherapy, so we can have some guidance to our patient when they are asking or seeking intervention. Are they going to the surgery, or we have other options using our scopes? I don't have any disclosures related to this topic. So, endoscopic management options for GERD include the radiofrequency application, the striated procedure, endoscopic fundoplication. We have the GERDix and the Isofix, and the anti-reflux mucosectomy. The striated is a radiofrequency application, involves delivery of thermal energy to the muscle of the gastroesophageal junction at gastric cardia. Multiple studies have shown striated to be effective in therapy in patients with GERD. When long-term follow-up study, including more than 200 patients, about 72% of patients significantly improved the GERD quality of life, with 64% achieved more than 50% reduction in use of PPI. We don't say that you will get rid of the PPI, but you will just improve your quality of life. And one important topic in patients with refractory GERD, that even on high dose PPI, they're still complaining. So if they will use PPI occasionally or lower doses, and they will achieve a better quality of life, this is very important. The application devices, we have the Isofix, or the oral incisionless fundoplication, and the GERDix. The basic principle is similar for both. For endoscopic plication, involves reinforcement of the gastroesophageal junction using multiple plications or fasteners, and in a systemic review and meta-analysis, the TIF was found to be safe and effective in patients with refractory GERD. Overall, in adverse event rate was 2%, and I will show you one of them. And PPI therapy could be discontinued in like 90% of the patients after therapy. Now, what about the ideal candidates for our endoscopic anti-reflux therapy? They must be mild esophagitis, very small hiatal hernia, less than 2 centimeters, endoscopic scales grade 2 or maximum 3, absence of Barrett esophagus, of course, and non-morbid obesity. This is the inclusion criteria when we use the applicators. Mucosectomy. Besides the radiofrequency and the fundoplication, of the recent studies have evaluated the efficacy of endoscopic band ligation and cap or multi-band assisted anti-reflux mucosectomy. The basic mechanism is tightening the gastric cardia as a result of the scarring after the band ligation or endoscopic mucosal resection. It should be noted that these techniques need to be standardized and evaluated. Let's have some pictures and videos. This is the GERD endotherapy. We are aiming to augmentation of the LES or remodeling of the flap. Augmentation using the striated device, remodeling using the TIF, Isofix, or Muse, or ARMS, or ARMA, and the full thickness plicator, the GERDix device. This is the GERDix device. This is the tip of the device. We can see 2 arms. We put the stabler in the 2 arms, and we have a helix inside to grasp the tissue inside. This is the controlling unit. We can see a port for the endoscopic channel, which is pediatric channel, maximum diameter 7 millimeters. And we have a retroflex control lock like the scope, so you can make your retroflexion in the stomach. You have the hydraulic pump lever. We use the hydraulic pump lever for everything, using the hydraulic controller for opening, closing, and firing the stabler. And for sure, you have a retractor handle for the helix. So this is a short video or edited video after placing a guide wire, and the guide wire is very important in this technique because the GERDix is very thick and very long and very tough, and introducing it maybe be difficult in the beginning. So we use a guide wire, and you have to use it cautiously. I will tell you in the other video the importance of the guide wire. After the guide wire, we start putting the device. Okay, now we are inside the stomach and we have a retroflexion, and using the pediatric scope to have a vision, then we open the arms and using the helix to grasp the tissue inside or the fold inside at the G junction. We were inflating the stomach with air because we have a very big device, and after grasping inside, we start deflating so we can help in grasping as much mucosa fold as we can. So we can have a full thickness double layer fold. So we are having some air suction now to help grasping the tissue inside. I think now we have the double fold inside. Then we close the arms and fire the suture. After we finish firing the suture, we open the arms again and get back the retractor or the helix to its position by rotating anti-clockwise. Now we lead the tissue with the helix. And then don't forget to close the arms under vision, because you cannot get the device out of the patient unless you are closing the arms. So this is very important tip. We have still under vision, and we have to close the arms again. Yes. And then we take it outside. We can see the stapler in a very good position. Even in easy procedures, bad things can happen. I'll show you another video. After introducing here, we can see a mucosal injury. It's like an ulcer. This is induced by the device. And I'll tell you how we think it happened. Using the guide wires, maybe the assistant pulled the guide wire faster than it should be, and the device wasn't fully in the stomach. So we believe this injury was because of the device. Now we are inside with the device and the baby scope, so we decided to continue our procedure, then to check the injury of the mucosa here. So we finish this case, and then checking by a regular gastroscope. This short video is just for showing the 2% complication. This was my first case to see a microperforation after examining the injured mucosa. Okay, we're just checking. I think we have a small perforation here. Do you agree, Dr. Mohammed? Okay. So we had to finish our job first, and then we check with another gastroscope. So to deal with the complication, we used hemoclip. And I think it's sealed. So even in easy procedures, you have to make sure that everything was okay, or you have to deal with your complications correctly. This patient was discharged at the same day. Okay, what about the radiofrequency ablation? Is catheter applied thermal energy 1 to 2 centimeters below the LES through to promote the LES muscle remodeling, decrease tissue compliance, and decrease the TLESR. This is a Strata device. It's computerized calculated radio frequency to the point at the LES area. It's a catheter This picture is from our unit. After making your endoscopic measurements, we use the catheter or the strata, which has irrigation and suction port, cable port connected to the controlling machine. You just have to put it in the right position and everything will go by the machine itself. Air channel and the sliding push button release 4 needles at 0 point of the catheter. And this is how it works. So it's automated and you will hear the voice after it finish. When you hear the voice, you finish the first level and then you go to the other level. The TIF is like the Gerdix, it's the same theory. Reduce a small hiatus hernia, less than 2 centimeters, create a 2 to 4 centimeter valve. But the only difference between the TIF and the Gerdix is that the flap here is longitudinal, in the Gerdix it's horizontal. So this is mainly the only difference between them. The mucosectomy, arm and armband. I think you're all familiar with Professor Ino. Professor Ino was doing some resections in the esophagus, and he discovered that all patients are coming with dysphagia because of the scarring. So he decided to use or to do arms or mucosectomy in order to treat GERD. It's mucosal resection resulting in scar formation, resection of gastric about 2 centimeters and esophageal mucosa about 1 centimeter in crescentic fashion to avoid dysphagia after the procedure. This is how it looks before and after. The ARMA is the same concept but using ablation. We can do it by ESD knife or now you can do it by forced argon coagulation. And the arm band, all are doing the same theory. I think this is the recommendations of surgical endoscopic options after GERD. We can see that TIF is recommended in these recommendations, Strata as well. This is the algorithm of treating refractory GERD. You have to go through it before deciding to make endoscopic procedure. My take-home messages, like Dr. Mohamed Salah said, are not regarding the techniques, it's regarding dealing with GERD. It's common, but many patients don't seek for advice. Lifestyle is very important. PPI compliance and optimizing of therapy is important. Surgery is an option. And new endoscopic techniques still under evaluation. Ideal candidate, don't forget ideal candidates for endoscopic anti-reflux therapy, mild esophagitis, small hiatal hernia, endoscopic hill, absence of Barrett esophagus, and non-morbid obesity. And thank you.